Good morning, everyone, and welcome to our Opioid Guardianship Project Take 2, looking through a new lens from pain to comfort. We're very excited to be meeting again and giving more information. I apologize for the beeping that's going on. I'm not sure what the cause is, but just so you guys know, right now everybody is muted. As we do have our speakers talk about the things that they're going to talk about, we will unmute them. But at this point, we're going to keep everybody muted. If you'd like to communicate, please come through the chat and we'll go from there. And today we will have Sarah Durr, our pharmacist at Iowa Healthcare Collaborative, and myself, Jennifer Creekmer, presenting. Just a reminder of the purpose of this project is to reframe pain to focus on comfort and functionality, to create a culture of judicious opioid prescribing, and to utilize treatment plans.
How I get the volume.
And yes to the everyone. Oh yes. Oh, yes.
And I'm just going to give a reminder, if everybody could mute their phones, that'd be wonderful. Our platform is not allowing us to mute everybody, so if you guys could go ahead and mute your phones, that'd be wonderful. Anyway, who can participate? As you look at this list, just a reminder again that you will see that many disciplines need to be involved in this. This is not just a one-person job, and this is supposed to be for everybody. So when we look at this purpose statement, a lot of hospitals, what they've done is they've either created a charter or an aim statement to go ahead and make sure that this process is being project focused. So the benefits of participation are data analysis provided by the Iowa Healthcare Collaborative, multidisciplinary evidence-based best practices, and emerging new resources provided, participation in the comfort research study to show efficacy of the comfort scale, which we're going to hear about today. We're very excited to roll this out. I think as a group of 43 hospitals, this is going to be fabulous and national recognition.
All right, well, hello everyone, and thank you for joining us today. As Jennifer said, my name is Sarah and I'm the pharmacist here, so I just wanted to give a little bit of background on some state prescribing data that we pulled from the Centers for Disease. So the CDC has this information on their website that you can actually take a look at, and if you're interested in drilling it down a little bit more deeper to either your county level or even looking at the United States as a whole, I just wanted to share some of their prescribing rates that they have on their website. So again, this is on the CDC website. We have the website there at the bottom. And they have every year for each state and the United States as a whole, either at the state or county level from 2006 to 2016. So looking at Iowa, we can see in 2006, there is a lot more lighter colors. So the darker the color, the higher the prescribing rate. And that yellow color is around 57 prescriptions per 100 persons. When you get into that little bit deeper of that red, and then the dark red, you're looking at about 100 prescriptions per 100 persons, or greater than 112 prescriptions per 100 persons. So in 2006, you can see that we've got a little bit more yellow, a little bit of red, a little bit of orange. And then as we move into that 2016, you can see here in Iowa that our prescribing rates really did increase. We are seeing a lot more of the orange, the red, and the deeper red even coming in on that south side. I am interested to see what 2017 looks like. That data has not been released at this point. As we do have a couple of hospitals participating in South Dakota, we wanted to share that data as well. And the white here shows that there is actually no data in that county. So in 2006, you can see there's a lot of yellow, a little bit of orange, and then some red, but not very much. And then as we get into 2016, again, we're seeing a much higher rate of prescribing occurring even in South Dakota. So the reason we're showing this data is really just to show that we do have a higher level of prescribing that is happening, not only in Iowa and South Dakota, but across the United States. And some of the resources we are sharing today will help show how we can combat this prescribing by looking at pain and moving more towards comfort and functionality. So like I said, we have some tools that we are making available today, and we will get these posted on Innovation so that you are able to access these tools. You can customize these, all of these tools to fit your hospital and what your needs are. We just ask that you leave the logos on the bottom of the comfort scale and comfort menu and those. So you can see we have the IHC Partnership for Patients and then the Compass HIN logos on there. We do need to leave those on there as we are in the process of getting this copyrighted, and so those do need to be present on the scale. For those of you that participated in the first cohort, you can see that we have made some changes to our comfort scale. And the comfort scale is really meant to move away from talking about pain as more of a negative side of things. When you say, do you have any pain or what's your level of pain? Oftentimes people will do a full body scan and say, you know, I do have a little bit of a backache, my knees are a little bit sore today, and they'll rate their pain a little bit higher because they did that full body scan in a very subjective way. When we're talking about comfort, again, this is still a subjective menu or a subjective scale. However, when I ask you how comfortable you are, typically patients will say, you know, yeah, I might have a 4 or 5 of pain, but today I'm pretty comfortable. And so utilizing this scale can actually reduce the amount of opioids or pain treatment that a patient may need. And we can work more towards hitting that comfort and talking about functionality and what they're able to do rather than focusing on pain. Like I said, the scale has changed quite a bit since our original version. And we actually went through a focus group that included physician, pharmacists, the occupational therapy, physical therapy, athletic training, and we also had some patients on this focus group. And what we found is that we needed to make some changes to make it more functional and easy to use. So some of the changes we made include removing the stars that were underneath the faces that still kind of indicated a numerical scale, so that this is much more of a non-numerical scale and you're actually using it to rate your comfort. We also spaced out the faces a little bit more so that patients could point to either a face directly or go in between the face if they were kind of in between comfort and very comfortable or uncomfortable and somewhat comfortable. They can point a little bit easier on that. We also changed the eyes and the mouths to be black rather than white, as in some cultures, the white eyes can actually talk about evil or make patients think about something more on the negative side. So we did make that change. And then lastly, we extended those lines out underneath each of the faces to really show the difference in that and the scaling that comes with that. So this is our new comfort scale, and we will get this posted on Innovation. Our next resource is our comfort menu. And this, again, is something that you can customize to your hospital. So we will get this posted on Innovation as well. And this is meant to be used at the bedside when a patient is in the hospital, so they can choose what might make them more comfortable. So a lot of patients won't realize that they can, for example, brush their teeth or ask for something like a shower or ask for an extra pillow when they're in the hospital. So this allows them to really pick the things that are going to help them. It is suggested that you actually can laminate this and have patients circle what they would like to have, and then you can even send this home with them and circle the things that worked well for them. Underneath the medication section, we do request that you try not to change this unless absolutely necessary, as we took some great time and care into making sure that we put the correct things under there that really fit with medications. So we talk about goals, we talk a little bit about allergies and discussing side effects and making sure that patients share every medication they're on. And then we also talk about some non-opioid therapies such as Tylenol, Advil, and naproxen, and you can change those if your hospital does not offer certain medications. But lastly, we put on there, while opioids have their place, they should be started at a low dose and stopped as soon as possible, as we do not want to shame anybody who does need an opioid and let them know that it is okay for them to be taking if it is correctly indicated. Our last resource here is the treatment plan. And this says post-op comfort plan at this point, but you are able to change this and really utilize it in whatever unit you would like to be doing at your hospital. So we've had some hospitals change this to say emergency department comfort plan or even just comfort plan. So it's up to you how you want to change that. This really walks through the goals that the patient may have and making sure that they know what medications they're taking, what they're taking, why they're taking it, when they should take it, and what the next few days are going to look like when they are discharged so that they know those medications. Again, we have our comfort scale on here that we will update this so that the stars are no longer on there, but that's also there for their reference on their comfort plan. We do have options for improving your comfort listed, so you can either use the comfort menu and circle the things that they can try when they go home, or you can even put information down about what medications they're taking, options that they have in order to better be comfortable once they go home. And then we also have some information on questions that patients can ask. So we found in our time working through this project that patients really don't know what to ask about their medications. So we have questions such as, what pain medication am I taking? Why am I taking it? How should I take it? What are the side effects? And when should I stop taking it? And what do I do if I have leftover medication? So all of those questions are listed to really empower patients to ask those questions of either their primary care, or when they are discharged, asking their discharge nurse or those folks in the hospital. And then we have information about putting in their primary care provider, what number they can call in order to get an appointment scheduled when they do go home. And then lastly, we do have call 911 immediately if they have any signs of an overdose, or if they're having any side effects from their opioid that may be leading them to respiratory depression or those sort of issues. I did want to point out that all of these tools are very person and family engagement friendly. We intentionally made them that way so that it is empowering the patient to really do that self-care and be part of their care. So as you can see, each tool engages the patient to think about their comfort level, so really thinking about them personally. It allows the patient to choose what will work best for them in order to increase their comfort. Provides an action plan when they go home, so they actually have steps to take in order to take care of themselves upon discharge. And it really empowers the patient to ask questions, and that's a big piece that we find is important for patients. And the last resource that we will be putting together and getting out to all of you is our opioid resource. As you can see, this is for Avera Holy Family Hospital, but what we have on here, as we collaborated with the Iowa Pharmacy Association, is the medication disposal sites, so where are those located in your local community? Where are treatment facilities that are present in your local community? So we'll have that information as well. And then lastly, we have which pharmacies are participating in the standing naloxone order, where a patient can go to get the reversal agent, naloxone or Narcan, without having to have a prescription. They can just go to the pharmacy to get that either for themselves, or if there's a loved one they're concerned about may overdose. And with that, I will pass this back to Jennifer to get us started.
Wonderful. Thank you, Sarah, for all that information. And you know, for those of you that are returning to this project, when we look at those comfort resources, that's where we started. That's, you know, and what we're going to see now is we're going to see how hospitals from the first group went ahead and took these resources and they made them their own. And so as we get started today, I'm going to go ahead and I'm going to unmute Susan real quick. And remember, through this process, I will unmute everybody. At the end, so we can get questions. If you can hold on just a second, I'm trying to unmute Susan to get started. If you have any questions, you can put them into the chat. And what I really need to do is, Susan, if you could go ahead and let me know what number you're calling in so I can go ahead and unmute you. And while we're doing that, Deb and Sally and Arlene, if you guys could do the same, if you could just put into the chat section what number you are. When we do hear that background noise, that's because somebody has their computer speakers on. So once again, if you could call in instead of using your computer speakers, that would be wonderful. And I apologize for the delay here. And if I could have all the speakers, if you guys could go ahead and just put the phone number that you're calling from, so I can unmute you. That would be wonderful. Okay, we're getting those phone numbers coming in here, so please bear with us. Okay, wonderful. Susan, can you go ahead and do just a test so we can see if we can hear you?
Sure, are you able to hear me?
Yes, wonderful. Thank you, everybody. So we'll continue on here. So once again, I think that you guys are really going to enjoy hearing the successes that these facilities have had. So I'd like to start by introducing Susan Kirstein. She's proud to be serving as Broadlawn's nurse since 1987. She has served in the positions of staff nurse in the Family Birthing Center and OB Clinic, Director of Women's Health Services, Director of Imaging Services, Operations Director for Acute Care, and for the past 10 years as the Chief Nursing Officer. In this position, Susan is responsible for the coordination of nursing services, quality, and accreditation compliance across the medical center. So Susan, I just want to acknowledge that a lot of our comfort resources have been in collaboration with you. We really worked closely with you. And also just to let everybody know that we did receive a lot of quality comfort menus and other things that we did taken into account. But Broadlands has been our mainstay for putting all of these tools together. So Susan, welcome.
Thank you so much. Glad to be here and be asked to help share how we started our project and some of the things that we've learned that hopefully will help other people along their journey as they start this project. The first thing that we did was pull together our core team of folks to get together. And so we had nursing from our inpatient area, our ER, and our clinics. We had a family practice provider who was very interested, and then we had a representative from our pharmacy who was also very interested and engaged. And that initial group started talking about how we were going to select our pilot group of patients to first start working with. And we talked about, what would be a population, first of all, that we had an opportunity to do some pre-surgical planning with, that definitely did go home on opioids. And then we also looked to see where we had some previous challenges in opioid overuse. And we did note that we had concerns with our orthopedic total joint patients, as far as a couple of times having to give some Narcan even on the floor to those folks. And so we decided to have that be our pilot population, those patients who were undergoing a total joint replacement. And those would be just our hips and our knees at this point. So we added some additional folks to our core team to reflect that population from our orthopedic clinic and then also from physical therapy. And we started reviewing what our existing processes and tools were that we could use as a place to start rather than needing to just go completely from scratch. Next. The current process had been that a nurse in the orthopedic clinic was meeting with the patients preoperatively in the clinic to just provide them some general education about their surgery and their recovery process. We have a fairly small population, so it wasn't enough people to do a full joint camp or anything like that, like some places have, but she did do some one-on-one education with those folks prior to surgery. She was also going in and visiting the patients in the hospital once they were post-op. And additionally, she made phone calls after they went home to check on them. So we had some good basic pieces already that existed that we were able to build on there. What we were missing was documentation, a great deal of this. And definitely we did not have anything as far as a goal setting and a real plan for pain management. We also didn't have a lot of specific information being given to the patients about opioids, the precautions for their use, and some of the potential implications for use of them beyond the acute stage. Next. One existing tool that we had on the medical surgical unit was a comfort menu. And these were non-pharmacological options that the patients could choose from. Their nurse or their healthcare tech know that they would like to try them. And we had actually started this as a patient satisfaction initiative and had some good results from that. Patients really did seem to like it. Our nursing folks were used to the patients having that comfort menu and used to them asking for things. And we had already started developing an aromatherapy protocol so that we would have a policy to go along with the aromatherapy that we were beginning to use. Next. So this is the comfort menu after the Iowa Healthcare Collaborative staff did a lot of work with graphics and some of the wordsmithing to emphasize the concept of comfort goals, as Sarah had talked about. So this is laminated. It's available at the bedside for all of our med-surg and our ICU patients. And the admitting nurse reviews this with the patient, and then it is offered periodically after that as well. Next. Next, we needed to tackle how to come up with a post-op comfort plan and the goal setting piece. So we reviewed a number of the examples that the Healthcare Collaborative had posted on Innovation. We drafted what we thought might work for us specifically for our total joint patients, and then we rolled it out to see what would happen and what the patients thought of it and what the nurse working with it thought. And we've made, since then, many different changes from the original draft as we received feedback from the staff and the patients. Next. So this is what our plan looks like right now. It's actually 2 pages. This is the first page of it, and it is not going to look like this for very long at all. We actually had a meeting yesterday with our second pilot group, and we're going to be making many, many changes to it. But we started with just setting some goals for patients after discharge. But we soon realized with the patients that we needed to include that time immediately post-op in their goals while the patient was still in the hospital. So you can see that we've added at the top of this initial time frames. So while they're still in the hospital, that first 24 hours post-operatively, and their next 24 to 36 hours post-operatively before we start having them set goals for once they get home. We also had some feedback from patients that it's hard to write in their goals from the comfort scale in that small space there at the top. And also that unless a patient had been through this type of surgery before, they were having a hard time knowing what was realistic as far as what goals they should set for themselves, both for their comfort and then also for their functionality at each time period following the surgery. And so that was one of the main things that we spent a lot of time at our meeting actually yesterday. And we've added, made that top now much, much bigger, ran it the other way on the page, added a way for them to simply circle their comfort goal at each stage. So those are all written out. And then we've added some functionality goals from the Johns Hopkins scale and added those in. So it's a much more extensive goal setting area now. That can all be changed based on the type of surgery that they have. So there's a column now as well for them to type in or for them to write in what should be their usual activity level based on the type of surgery at each stage. Next. And then the back of the plan includes just some very basic general information about the safe use of opioids, including how to just gradually decrease the use of them and why it's important for them to do that. And then we added a mini comfort menu at the bottom. So these were items that patients and their families could use to plan for their recovery once they were home. Hopefully, as they worked with their clinic nurse ahead of surgery, they were able to come up with some of these things and have them ready for when they got home. So we're modifying this basic document actively right now for other types of scheduled surgeries. Next. Some of the other activities that we did during our pilot were to plan and carry out a community meeting specific to the needs of our pilot group. So we invited folks from skilled care, long-term care, home health, DME. We had just a very small group of people that actually did come and attend, but they were very engaged, and they seemed very happy to have the information that the collaborative staff was providing about the initiative and about how they could continue some of those efforts once they worked with our patients post-discharge. We also pushed out education to our providers on the use of the prescription monitoring program, and we made it available so that they could have just a couple of clicks off of our intranet site so that it's very convenient for them to use. They don't have to go search for it out there on the internet, just a couple clicks and they're in. Our pharmacy representative did a great deal of research and legwork into getting Broadlands designated as a narcotic disposal site. And we just actually got all the DEA licensing changes completed and the unit is installed. So we've got one final approval of the policy for checking that, that disposal unit, and then it'll be up and running, and we'll be sending posters out to all of our clinics, letting patients know that they can dispose of narcotics right here on site, and having some handouts that will go with the narcotic prescriptions from our pharmacy. We've also added some more providers to our core team. We have a psychiatrist who is also developing a medication-assisted treatment program in the very near future. We've got a nurse practitioner from our pain clinic, and we have a Suboxone certified family practice physician who've joined our core team, and they're all very engaged and interested in this project. Next. So while that all sounds good, everything was not rosy by far. Some of the barriers that we encountered were a major upgrade to our Meditech electronic health record system that happened right in the middle of the pilot. So all of our reports for our data had to be rebuilt. All the plans that we had for the documentation changes in the record had to be put on hold, and frankly, still haven't all been implemented. We did find that trying to implement some of these changes on the medical surgical floor was very difficult, with them just affecting the small pilot group of patients. It was kind of confusing for the nurses to know when they were supposed to be using the comfort scale, when they weren't, and we found that it often was just forgotten, particularly without a good way to document that in the record. And then, about a month ago, one of our orthopedic providers announced that his clinic would no longer be participating in the project. So, you know, that was fun. He didn't feel that he saw value in it and felt that he just didn't need help managing the opioid use for his patients. So obviously we had a real big disconnect there, and we needed to figure out how to avoid that kind of a disconnect in the future. Next. So some of the lessons learned involve the floor staff right from the very beginning. So this is now a standard topic at our Nursing Professional Practice Council, which is our self-governance staff nurse council. So they're actively discussing the initiatives, the data, how to help implement the new pieces, and our core team will have a council representative from that group of nurses. We are getting more direct buy-in from the involved providers at every stage of the project. So that is something people will want to do. Talk about the reasons why you're doing this, the benefits to their patients, and reinforce it over and over and over. I would figure out how to get the initiatives documented in the medical record right away prior to rolling anything out. That just would help with sustainability and with helping everyone to understand it clearly. Decide that it's okay to start small. You don't have to implement every suggested initiative all at once. And then decide what information that you really want to end up with realistically from your data collection. And then design your data gathering processes accordingly so you don't end up having to do rework. We decided we wanted some additional details on our ED patients who had received Narcan, and I ended up having to pull records, you know, a couple of different times in order to get that information. Next. The next steps that we have are rolling out with our scheduled podiatry procedures and our GYN procedures. And we just actually had our initial meetings with that group yesterday, and they went really very well. And then we'll be revising the post-op comfort plan for those particular patient populations. We're building documentation in the EHR for the use of the comfort menu interventions as well as the comfort scale. And we're rolling out our posters in the clinics about our narcotic disposal site. Our pharmacy is working with local law enforcement and some of the area college campus security to get them trained to carry and use Narcan in the field. And then we're modifying our staff education and our policies to reflect the new Joint Commission pain management standards language, and trying to figure out what we want to document for this project so that we can review that when we have our Joint Commission visit later this summer. So hopefully that helps gives you a starting point for your own projects and maybe helps you avoid some of the pitfalls that we ran into. Thank you.
Thank you so much, Susan. I'm going to go ahead and attempt to unmute everybody. We'll see how the noise level is, so just bear with me.
Stop in anything you're on about. Stop in at the hospital front desk.
Okay.
And then
We can hear whoever's talking in the background. If you want to go ahead and mute your phone. All right, I'm going to have to go back and mute. And what I'd like to do is have everybody put their questions into the chat section. And as you're listening, what would be really nice too is to have you guys go ahead and write your takeaways, what you're taking away from these, because I know as Susan talks and as we basically practice for this webinar, I was just writing so many great things that they're doing and building on, and it's the continuous process improvements and the PDSA cycles that are going on that are making this program amazing. So once again, Susan, thank you so much, and we'll be looking in the chat for comments. And once again, here's Susan's contact information if you have any questions. Next, I would like to introduce Community Memorial Hospital. We have two speakers today for Community Memorial. The first is Sally Youngtum. She's been a registered nurse at Community Memorial Hospital for 31 years. She worked as a floor nurse in all departments for the first 25 years and currently holds the position of risk manager, quality coordinator, occupational health nurse, education coordinator, and works PRN as a circulating nurse in the OR. Sally has been instrumental in developing CMH's Community Care Transitions Team, the Person and Family Advisory Council, and facilitates various improvement projects. We also have Deb Varner. She has worked as an RN for CMH for 21 years. Her primary job is clinical informatics specialist. She also is the team lead for the Fall Prevention Committee and the UPH Health Literacy Collaborative. She developed and coordinated the activities program. She is currently working with readmissions, C2, T2, and opioid committees. So let's go ahead and see if Sally and Deb are on the line. We're able to hear them. Okay, Sally.
Okay, can you hear us, Jennifer?
Yes, loud and clear. Thank you. I'm going to go ahead and turn it over to you.
Okay, thank you. It's a pleasure to be here today. Thank you to Jennifer and the Iowa Healthcare Collaborative. Community Memorial Hospital is a critical access hospital nestled in the northeast corner of Iowa. We have 12 inpatient beds. And we decided that we would like to be a part of the opioid guardianship cohort when the first one was introduced. So before we got started, if you'd like to do the next slide, please, Jennifer. So in the beginning, our pharmacy tech and I got together and did a little bit of research on the issue of opioid abuse and misuse, especially within our walls. Our pharmacy tech has done an amazing job. Every month she monitors and collects data on what type of opioids our patients are being discharged on. And we found out some really amazing things. There's times in the past when patients were discharged on 120 oxycodone or 2 different opioid prescriptions. And so we knew that we had some work ahead of us. So we got buy-in from our administrative team and also formed our opioid guardianship team. Our CNO is our administrative lead, and then we also included our nurse manager, our pharmacy tech, our informatics, and that would be Deb, who's here today too, our clinic care coordinator, and myself. We researched the interventions as a group and also our prevention strategies that we were using and decided on some improvements to be made. Some areas that we identified as really being underutilized at Community Memorial was that our physical therapy department was not being utilized when it came to patients who were experiencing pain or discomfort. We also discovered that some of our providers were not in the PMP, so Deb was instrumental in having that embedded into the EHR, and we do use the EPIC electronic medical record. We also decided that we needed to be introducing the pain scale right away on admission to the patients who were prescribed opioids. We do use our whiteboard. We have our the old pain scale, the numbered scale on our whiteboards. So we are utilizing the whiteboard even more. We also knew that we had to get some buy-in from our medical staff. So Deb did some education at our med staff meetings, and so did our CNO. She gave the providers some information on, that our pharmacy tech had collected and showed them what type of opioids our patients were being discharged on. We also had all of our nurses do a net learning module on documentation of pain and interventions within EPIC, and that was actually provided by Unity Point Health because we are Unity Point Health and we are using that type of documentation. Next slide.
There we go. Hi, welcome. I'm Deb. Can you hear me okay?
Yep, we can hear you perfect. Thank you.
Great. We began by developing a comfort menu, and we looked at a lot of other comfort menus that were available, and then we assessed to see what we could offer our patients to make them more comfortable. So we developed that comfort plan, menu, and then we presented it at our nurses' meetings. We also developed some new interventions that we had not offered previously at CMH and gave demonstrations at our meetings and are encouraging our staff to utilize those with our patients. And some of those would be a hand massage, guided imagery. We purchased some CDs and DVDs and gentle stretching. Next slide will show you our comfort menu that we developed. We just broke it up into sections, comfort items, comfort actions, personal care, the relaxation options like the guided imagery and the soothing DVDs, things if they're just bored that we can offer them, and when we would like the patient to let us know if they're having more discomfort and what to talk to their nurse or healthcare provider about. Next slide, please.
So some of the key concepts that we are doing here at Community Memorial Hospital, We are offering the comfort menu and utilizing it with all inpatients prescribed on analgesics. So even if they have Tylenol or ibuprofen, we are introducing the comfort menu to them too, because we never know if that discomfort or pain is going to escalate and require opioids. We also discuss the comfort menu and help the patients determine their pain goals when they are admitted, and then we talk about those pain goals and what comfort menu interventions have been helping. And we discuss this during bedside reports. So they hear about this twice a day. Also, the nursing staff offers comfort menu options with all patient-reported discomfort. And we've really tried to drive home to our nurses that we should never undertreat their pain, the patient's pain or discomfort, especially in the acute care setting. And the nurses have been really good about that as well. And then the attending provider only prescribes enough opioids to get the patient to their follow-up visit after discharge. And we determine that from their LACE score. If their LACE score is 9 or less, their follow-up visit is a 7-day return. And so that's how many opioids the physician or the provider will prescribe. And if the LACE score is 10 or greater, then it's a 3-day follow-up visit. And so they only get enough to get them to their follow-up visit. Next slide, please.
So we decided to build a comfort plan as well as the comfort menu. And within that plan, we wanted it to be part of our patient's transition of care. So in order for it to follow the patient to their primary care physician after they go home, we wanted to make sure it was in our electronic health record. So we did that, and like we said, we have Epic. We included it in the patient's discharge instructions so that it shows up in their after visit summary. So then our providers will be able to see that as a follow-up. So the way we did that, we created a smart text that was available to all the nurses, and it has the whole comfort menu in that. So they just would go to this butler, they call it, in their discharge instructions, and they're able to add that comfort plan and individualize it per patient. So included in our comfort plan is, well, I guess you can do the next slide. I think it shows some of that. So our comfort plan will show their comfort goals at rest and moving. The nurse will underline any interventions. Just further down, I know it's not included in the slide, but it'll show the comfort plan, and the nurse will underline that plan, the interventions that they are using in the comfort menu. And we also put in some options for improving their comfort level. We address some of the side effects that could be caused by medications and what they need to report to their provider on their follow-up visit. As you can see, these are the comfort scales that we use here at Unity Point. So we have the Wong-Baker and the thermometer scale, so that the patient can show their provider on their follow-up where they're at on their comfort level when they go to their return visit.
Next slide. So of course, we also had some lessons that we learned. We knew from the beginning that we really would have liked to have frontline staff involved in our cohort in our initial group. But it was difficult to find frontline staff that could dedicate that time because we did meet weekly. We probably could have, not set a date and time every week, but gone according to a nurse's schedule and maybe met before her shift or after her shift, you know, to have that frontline input. We also need to review the new project repeatedly to get it hardwired with our nursing staff. So Deb has been doing that every month at the nurses meeting, and they are catching on. We've been doing some one-on-one education with them as well. We should have sent out our minutes that I took at each of our meetings to the frontline staff so that they could understand what was happening as we progressed throughout the initial cohort. And then we would have really liked to have had a medical staff champion. We do have a provider now that is on our opioid guardianship committee, take 2. Unfortunately, he hasn't been able to make it to any of our meetings yet, but he did agree to be on our committee. Next slide, please.
So in the future, we want to continue to hardwire our interventions with the comfort plan and the comfort menu onto the hospital side. We want to get our nursing staff to offer that comfort menu with their patients when they do their hourly rounding. We feel that's a real weakness, and we want to continue to work on that. After we have it hardwired on the hospital side, we'd like it, we'll work on getting it hardwired into the clinic side so that it is a usable form for the transition of care. We want to continue to involve our medical staff champion, and like Sally was saying, and then we want to monitor our patients' perception of their pain control. We don't want our patients to feel like they were suffering in any way, so we'll be monitoring our Press Ganey and our Epic reporting.
Okay, thank you, Jennifer. Next slide.
Wonderful, Sally. So this is Sally and Deb's information, and something that I really wanted to talk about here, Sarah's going to go over questions that are coming in. So if you guys have any questions, and I believe that we still, we can unmute Susan again too if you had questions for Susan. But Sally, something that you said that I really want to touch base on here is you did talk about the undertreatment of pain. This project is definitely not focused on taking pain medicine away from people that need it and opioids when they're necessary. So Sally, I really appreciate that you did touch base on that, and that was one of your key focuses in this project. Okay, so I am going to go ahead and let Sarah go over some questions that have come through.
Yeah, thank you, Jennifer. So Deb and Sally, we did have one question come through. How do you document, I know you mentioned a little bit about Epic, excuse me, but the question is, how do you document comfort versus pain in the EMR or in Epic? And was this viewed as a duplicate documentation by frontline staff?
I'm sorry, we missed that question. Can you repeat that, please?
Yeah, so the question is, utilizing your EMR Epic, how do you document comfort versus pain in the EMR, and was this viewed as duplicate documentation by frontline staff?
Well, the way we have our documentation, it is still called pain in our nursing documentation. So the nurse can take those pain scales and ask the patient to show them that, and they can convert that to a number that will go into Epic. And because that number is still important to us, because our order sets are all set up by that number, so the nurse can determine how she's going to treat that patient's discomfort by that number that they're given. And I know we're trying to get away from numbers, but that's why our FACES, our Wong Baker, has numbers under it, so the nurse can convert those FACES to the number that correlates with that, and that's how it's determined. And what was the other duplicate documentation?
Yeah, there was a question if frontline staff felt like it was a duplicate documentation if they had to go in to the EMR or if they had to go into several places in the EMR.
We only have it in one place.
So they didn't really.
And it kind of, there may be different flow sheets that have the pain scale and interventions available, but it all moves through to the information is transferred to all those places, so they don't have to redocument.
Perfect. And then one other question we had come through, and if we can unmute Susan's line as well, she can share this. How did you go about training your frontline staff on how to use these comfort resources? Was there some sort of training specifically set in place that they came to? Was it more of an individualized training? What did you do in order to make sure that you could really train the frontline staff not only on what these resources are, how to implement them, but why it's so important that we are doing this work around comfort versus pain?
We had started that again when we had rolled out just the comfort menu itself, and that was quite some time ago. And the director at the time just talked about that in her department meetings, and then also with some one-to-one discussion with the charge nurses to encourage that it continued to be used. She also went to like healthcare tech meetings to be sure that they knew about some of those different options. And then we just continued that same sort of reinforcement at unit meetings. We have a new director now for that department, and that's the whole piece about the comfort scale use is his real next focus with education for staff. Because we're just now developing a way to document that piece in our medical record. And so he's going to be spending quite a lot of time with the staff trying to help them figure out and to know how to document the comfort scale as well as just the menu.
Wonderful. I think it's great that you've got leadership on board with that. That's really a key piece in this work and in our project, is making sure that we do have leadership supporting us as we go through these changes, as it does take a lot of work. It's a heavy lift in order to get these things into the EMR or make some of those changes, and we recognize that. Susan, did you have anything to add on the training that you go through with your staff?
No, I don't think so. I think that's it.
Thank you, Susan.
Okay, so once again, if you guys have more questions, and I really want to reiterate here, we do have Innovation that we've asked you guys all to join. This is a great place to start asking these questions. So as you listen, especially if you're listening in a group and you come up with a question, you can go ahead and use Susan or Sally's or Deb's information here, or you can also contact them on Innovation and start a group discussion, because that's how we're going to learn together. Next, we have Covenant Medical Center, and this is our last person that's going to share today. We have Arlene Wright. And Arlene graduated from Drake University in May 1981, and for the past 27 years has worked at Covenant Medical Center in various pharmacy leadership roles. She has led roles in Joint Pharmacy and Therapeutics Committee, Pharmacy Residency Program, Joint Commission Provision of Care Team, Antibiotic Stewardship, Quality, Tech Check Tech programs, and most recently the Opioid Task Force. So Arlene, thank you so much for joining us today.
Well, thanks, Jennifer. Good morning. I am the pharmacy manager at Covenant Medical Center in Waterloo, Iowa. We have two sister hospitals, Sartori in Cedar Falls, which is about 10 miles away, and a critical access hospital, Mercy, in Owine, which is probably about an hour away. Everything I cover today is applicable at all three sites. Today, Jennifer asked me to share two of the documents, the Comfort Menu and our Opioid Prescription Resource Guide, that we developed to help address the opioid crisis. Both of these documents are included in the patient's admission packets for all patients, because we felt this was important information for everyone to know. It's highlighted during the admitting process and referred to often throughout the hospital stay. Next slide, please. We have always had a very active pain committee. It's comprised of several staff nursing representatives from all 3 sites in various departments, such as the surgical units, the medical floors, skilled nursing, labor and delivery, ambulatory surgery, outpatient clinic, pediatrics, and then pharmacy is also involved. Recently, they wanted to focus on the new Joint Commission proposed 2018 pain guidelines. So any of their initiatives were to align to meet these guidelines. One of the things they decided to do was create a comfort menu, and rather than reinvent the wheel, they decided to look at the intranet, and they found out that it offered an extensive amount of shared information. So Jennifer, if you could pull up our comfort menu. The members split up into several groups, and so they could identify items in the following categories: personal care, comfort items, comfort actions, medications, relaxation options, and combating boredom. Now, if you notice, several of these items listed, like warm blankets, toothpaste or toothbrush, extra pillows, ice packs, repositioning, walking in the halls, are things, TVs, are all things that all hospitals are offering right now. So there was not a lot of extra planning needed to implement this document. Next slide, please. Next slide. The head of the pain team, Tracy, designated her unit, which is the ortho-neurosurgical area, as the pilot. She trained her staff on how to use the documents, implemented it, and once their floor was comfortable with how they were using it and how it was working, Tracy educated the other nurse managers. She encouraged all of them to explore the best option or the best way for it to work on their units. It was then up to that nurse manager to educate their nurses, aides, as well as health unit coordinators, and then implement it on their units. Next slide. At Covenant Medical Center, there is a large Spanish and Bosnian speaking population. To help these patients communicate, the pain scale was translated into their language. And Tracy feels that this is one of the best things that we have offered our patients, and very, very simple. It helps these patients feel that they are engaged and that they are able to more easily communicate their way their pain is feeling. One of the other goals the pain team had was to translate from pain to comfort. Unfortunately, our computer system was not able to change that without a lot of money and time. So to overcome this, nursing is now using both terminologies. They're using pain and comfort when they talk to the patients. Next slide. Of course, medications do have their place in the treatment of pain. The following highlighted points, the patient and the caregiver, we want them to be involved with the providers and the nursing to help work out what will work for them. We want them to let us know what has worked in the past so that we can use that as a starting point. We want the patients to set realistic goals. We do a lot of total hips and total knees. And for a post-surgical patient, it's unrealistic on post-op day 1 or 2 to have or expect a pain score of 1 or 0. We want the patient to ask the nurse for a pain medication before their pain actually returns. Reassessment is also very important. We want, when the nurse goes in there, we want to find out how they're doing. And if the intervention hasn't worked after 45 minutes, we want the patient or their caregiver to let nursing know so that we can try an alternative treatment or suggest something different. Next slide. I wanted to point out also that all of those are consistent with the new Joint Commission guidelines. One of the relaxation options on our menu is aromatherapy. Many hours were dedicated to be able to offer aromatherapy. There was extensive research done on available products and administration techniques. This resulted in the decision to use high-grade essential oils using wicks and an inhaler. The scents we chose to offer are lavender, ginger, and sweet orange. Now, lavender is used to treat headaches, insomnia, and nausea. Ginger helps with indigestion, nausea, and pain. And the sweet orange we promote to help with anxiety, indigestion, insomnia, and pain. Before we could get this project going, they had to work extensively with materials management to help find a way to obtain these medications and the inhalers. They had to be able to get them into their storerooms on the nursing units for use. They had to work with accounting to set up CDMs for charging purposes. And of course, being in a hospital, you can't do anything without creating a policy and procedure. So in this policy, they identified the patient population that it was going to be used for. And they also addressed other patients as well as staff members that may have allergies or sensitivities to various smells. Of course, we had provider buy-in from the get-go. And once the policy was written and completed, it was presented at the Infection Prevention Committee, Pharmacy and Therapeutics Committee, and ultimately the Medical Executive Committees for approval. Next slide, please. Now we'll switch over to the other document, the Opioid Pain Medication Resource. All 3 hospitals participated in the first Iowa Healthcare Collaborative, the Opioid Guardianship Program. And this year, Wheaton has transitioned to be part of the Mercy Healthcare and has joined their committee. Projects completed last year will still be shared with the Mercy sites as well. The first thing we did to come up with this document was create a multidisciplinary task force. It was comprised of nursing, quality services, pharmacy, a physician assistant, and senior leadership. Now, the Iowa Healthcare Collaborative provided a baseline document that listed the take-back locations, addiction treatment locations, and where naloxone is available in our area. Now, our task force felt that this was a very good document to start with, but we felt that our patients would not understand or know what to do with this information. So this is our final version, and we wanted the patient to understand or know that there's dangerous side effects, even if these medications are used as prescribed. We want them to know that there is a national concern due to the misuse or abuse of these medications. We also wanted to take this opportunity to educate patients on the risks, the side effects, and naloxone, and where to get it, and what to expect if they ask for it. So we told them that it's available without a prescription. They know where they can get it. We tell them it's a nasal product so that they don't have to worry about injecting somebody and knowing how to inject a medication. They'll need to fill out an eligibility assessment form. It will be processed as a prescription to insurance, and they will get counseled. On the right in the red hand section is our highlighted our areas where they are able to be, for unused prescriptions to be taken. And then at the bottom of the document are the locations for our treatment sites that are available. Notice these are all also part of the Joint Commission guidelines. Next slide. So we did have some lessons learned as well. We had barriers too. As we were becoming just a new participant with Mercy, we were getting a new computer system. And towards the end of the Guardianship project, all staff was extensively involved in that computer implementation. So this allowed very little time, if any, to devote to the Guardianship program. We looked at some physician prescribing habits. We wanted to involve our orthopedic physicians because they do prescribe quite a few days of therapy. When we asked them to get involved, they were not interested in reducing the number of days of therapy because they were still concerned that they were going to get called in the evening and on the weekends more. The patient satisfaction tools still reference pain. And nursing and management was concerned that patients would not be able to make the correlation between pain and comfort, thus resulting in negative scores. I feel we did have some successes though in the short time we were active, is that since this was multidisciplinary, the individual members took this back to their departments and actively engaged their departments, their staff, and came up with processes and plans that they could do to help work towards a common goal. So we basically got a big bang for our buck as everybody took it back to their departments and was able to make some changes and implement things. The members were extremely engaged in the project, and their enthusiasm transferred to all the staff members. It's been a pleasure to share these documents with you, and I'm available for questions at the email address on the first slide.
Thank you so much, Arlene. I think that we had a lot of takeaways during your presentation, and Sarah and I were just, as we're looking at your document for drop-off sites, we really think that as we look at that, we may actually take a lot of components off that when we do present everybody with their documents, which will be coming in May. So thank you so much for sharing. Once again, if you guys could go ahead in the chat section, and if you have any questions, Sarah can go through those. I think there's a little conversation going on that Sarah will share right now.
Thank you all so much for sharing your comments and your thoughts. I know we had somebody ask Susan, was there already a site designated for their medication disposal, or did they become one as part of this initiative? And Susan did respond that they became a part of this, as a part of this initiative, they became one through asking their pharmacist how to actually get that set up. And just to clarify for all of you what that process is, I wanted to share kind of what our knowledge is on how you can actually get a site set up and have a medication disposal box without any cost to you or your facility. The Board of Pharmacy in Iowa is actually setting up these sites, and their goal was to have them in all 99 counties by the end of 2017. That was accomplished, and so all 99 counties have at least one drop-off site, either at a law enforcement location, at their local pharmacy, or within their hospital. And so if that's something you are interested in getting a site set up in your local community, please feel free to reach out to the board. And if you're not sure how to do that, you can always email me, and I am happy to connect you with the person to get that drop-off site set up. I know when I was at their Board of Pharmacy meeting in January, they have a goal of having an additional 50 sites set up by the end of June of this year, and they only have 9 more sites to go. So as you can imagine, they have had a lot of interest and a lot of people coming to them to get these sites set up. So if you are interested in that, please let me know or contact the Board of Pharmacy, and we can go ahead and get those set up for you. At this time, we don't have any other questions coming in. Just a reminder to please put your questions into the chat box, and we'll address those at the end of the presentation. And with that, I'm going to let Jennifer talk a little bit more about data.
Thank you, Sarah. So as we move forward, of course, this project should be data-driven, so I just wanted to go ahead and show the data that we are asking that you collect. Just go over it real fast. So our adverse drug event rate, this is using the NIC-MRP scale, categories D through I, and you can see that this is the number of adverse drug events over the number of acute swing bed and observation patient days. This is sampled, it's self-reported, and most of you are reporting this. I think we're close to 100% on this. But what's really interesting, and I will share this on Innovation later, is what we did is we looked on our first cohort data, and not only did we see that the adverse drug event rate went down as a whole for our Compass 10, we also saw that the participants in the project dropped even more. So this is really good data to show you that the process improvement will affect more than just your opioid rates. The next one is the core of this project. It's the opioid therapy treatment plan. We're working through this together, and I hope you guys enjoyed the resources that you're seeing today and can really dig in with your frontline staff and others, but looking at the number of patients discharged from a hospital on opioids with patient-specific goals of therapy at discharge. And this is over the number of patients discharged on opioids. Once again, this can be sampled. It is self-reported. And even if you do not have your numerator at this time, please be putting in your denominator. And as I've had many discussions with many people, when we look at this denominator is going to be very foretelling for multiple reasons. We can break this down into number of patients that are new opioid prescriptions and old, but then also to break it down even further to say how many of these patients are hospice, or how many of these patients are this appropriate for, and then to start to offer more options for patients for discomfort other than just opioids. So I think that this measure will really, the denominators are really going to drive which direction you're going to work. Next, we have the statin naloxone administered on the inpatient population. This is self-explanatory. And then also the statin naloxone administered in the ED population. So without further ado, we're going to move on to talk about our comfort scale study. Sarah and I are really excited about this, and you guys are going to be part of a groundbreaking project that's going to take place, and we're really going to look at this comfort scale, and we're really excited to get started with what's your population that you're going to use and what we're going to see with this comfort scale.
Thank you so much, Jennifer. So this is pretty brief. I'm not going to go into the nitty-gritty research methodology or anything like that and bore you guys with that information. But really what we're excited about with this is the fact that it's going to be a translational research study. And what that means is it is a rapid cycle study that looks at the impact this comfort scale has on patient care, on how patients view pain, and overall on what this comfort scale can do around decreasing opioid prescribing and those sort of pieces. So with those components, we will actually use the quantitative data that Jennifer just went over. We will aggregate that for each of the hospitals as we have in the past, and then we will pull that and look at how that is impacted as we start to implement this comfort scale. So that is why it is so very, very important that you all get your data in around these measures, and then as you start to use this comfort scale, continue to put your data in so that we are able to look at how this impacts patient care. And I do want to say that we are super excited for this because we are very much expecting that this will have a positive impact on patient care, reduce the number of adverse drug events, and even reduce some of our naloxone use either inpatient or on the ED outpatient side. So this data is definitely going to be the key cornerstone of us getting the research done that we would like to get done. We will also be conducting an exit survey. This will be separate, most likely, from your post survey because we are having Drake University assist us with some of this research. And so they have an exit interview that they will do more around the qualitative data. And this may be actually a survey that you will need to take to your frontline staff or those that are actually utilizing the comfort scale in order for us to get the best information on how they liked the comfort scale, what patient reactions were, how documenting was. All of those pieces will kind of add in at that exit survey, which will be likely in June or early July. And so just keeping in mind that that survey will be coming, we definitely would appreciate if you can push that out to whoever it is that is actually working day to day with that comfort scale. From there, we actually plan to go ahead and get this published nationally once we get all of our data together. And I will share with all of you that I was actually at the CMS Quality Conference this past few days and had the opportunity to present not only on our comfort scale, but some of the work we're doing here at Iowa and what our data looked like with our first cohort. And they are very, very, very excited about the work that we are doing. I had several people come up afterwards and talk to me about what they're currently doing, how they would like to move this forward and start using some of these resources. So I really think that getting this comfort scale study done will just show how impactful this work is, and we can start spreading that even further nationally than we already have at this point. And then I did want to mention that with this study, we do plan to not only look at the inpatient side, as not all patients are inpatient at all times, so we will be looking in the clinics, and we will also be working with some long-term care facilities in order to pilot the comfort scale as well as get some data on that to see how it works in the outpatient side as well. So like I said, this is something that we will be doing over the course of the next 4 months or so as you implement this comfort scale. Make sure you're getting your data in, and then likely we will not have this published or out to the public eye until the end of the year or early 2019, just depending on when we get this pilot going in the clinics and what data we can collect from them. But you all are really going to be the driving force for this study, and your information and what you do day to day is truly going to impact not only what we find with our data here, but it's going to impact the nation on how we are starting to look at pain and talking more about comfort and functionality. So know how important your voice and your work and your data is going to be in order for us to actually make this a national movement and show the great work that Iowa does and get all of your names out there and show the great work that you are doing on a day-to-day basis. If you do have any specific questions around the comfort study or how that impacts your facility, please feel free to reach out to me. I know that we will be working with your local IRB if you do have one, so that we have an exempt status and get that translated over to your local facility so that we are able to do this research with you. But know that it is an exempt status, so we're not working with individual patient information. It will all be aggregate and high level. And I did have a question come in that I will have Jennifer actually address shortly here as we go through the next couple of slides. The question is, should Narcan administration PTA be rolled into ED or have its own metric?
Amanda, that's a great question, and we actually do have a measure that you can choose, and it's Narcan administered in the community setting prior to admission to the emergency room. So we do have that. Please contact me, or you can, if you're not the person that inputs the data, it is on the structure. You can choose that measure. We just wanted to make sure that we didn't make it so you guys had to report so much data, but this is definitely a step forward. I know many people that have been in this project are already submitting this data, but this is a great place What it does is it helps you reach out to your EMS and your law enforcement to really look at what's happening in your community prior to the patient arriving. So great question. Okay, moving on here, commitment to participate. When we look at this, we want you to make sure, and I think that everybody has done these steps, to identify an executive sponsor, assemble an opioid guardianship project team. I know that we've worked a lot on that, talked a lot about those on our Tuesday, every other week Zooms, and submit self-required, self-reported data. We just talked about those, so please continue to work to report that data. Complete the pre and post survey by the deadlines. We just have 2 surveys left. As soon as those are finished, we can go ahead and post the results. We'll also post those on Innovation to the surveys, because I'm sure you're curious to see you know, what's going on in the cohort, and then we will obviously do a post survey that will show the differences. Share successes and challenges. Once again, Innovation is a great place to share these, and I think today we had some amazing transparent people sharing on this. It was just wonderful. At least one team member will participate in each of the 4 webinars, the 4 main webinars. These also are recorded, and we encourage the entire team to watch these. To utilize the comfort scale in the sample population, Sarah just spoke to that, which is very exciting, and provide community outreach on the safe and effective use of opioids. That is something that you will see on February 28th. We will put those slides out, and then we will review that on Innovation on our Tuesday Zooms. That being said, if you are not part of our Tuesday Zooms, it's every other week. We just had one this week. Please have one person from your team participate if possible on those. There's a lot of good conversation around how to do this project and what other people are experiencing, so lots of questions are being answered during that time. Contact me if you have questions. I'll make sure to get you the link to join. The action items for success. Going forward, ensure your quality improvement efforts are driven by data. I think we've said that many times today, but again, we want to make sure that we're doing good PDSA cycles and we're showing good results. Plan on how to implement the comfort resources. Include your frontline staff. And I know that there's a lot of hospitals. War Memorial is one that one of their takeaways is they wish they would have got their frontline staff on board right away. And I think that we heard a couple other people saying that too. I think Sally said that. But your frontline staff is really important, especially for your comfort menu, so they can have their input into what they're going to be working with on hourly rounds. Identify your hospital patient populations to use for the data collecting and the comfort scale. And now that you hear about the comfort scale, you know, when we put that out, that'll be emailed to you. What patient population are you going to use? What makes most sense for your facility? Join and participate on Innovation. We'll try to start a few different discussions there. If you guys would like to start discussions for the opioid cohort, that would be wonderful. And then I also talked about our bi-monthly meetings on Zoom. Please contact me with any questions. I do want to quickly go through our upcoming opportunities. I already talked about this, the Train the Trainer education. We do have slides put together. You can copy and steal any part of those, but we also have scripting that we've worked on, so you do have talking points. We highly encourage you to personalize these, though, to make sure that your communities know what you're doing in your hospital and how you are giving them good customer service through this opioid crisis. We have our next training webinar that's Upstream Prevention, Tools and Best Practices. That will happen on March 15th. You will be able to receive contact nursing hours when you are on the live webinar, but this will also be recorded and available to you. And then our next main webinar is Breaking Down the Silos, Mobilizing Your Team. You'll hear some great testimonials from people that are already walking the walk on how they're mobilizing their team, how are they including their clinic, how are they including their community, and really where they've been and where they're going to. So you guys will really want to be part of this storytelling of the path of this project. So if you have any questions, once again, please go ahead and put them into the chat section. And these questions can continue on on Innovation as well. As always, Sarah and I thank you for your participation. And if you have any questions moving forward, you can contact either of us. This is our contact information.
We will stay on for the next minute or so to make sure any questions get answered that may come through on the chat section. And of course, I would like to make sure that our speakers know that they are appreciated for the time that they put in, not only to get the presentation ready, but to share and present.